Um, Good evening, everyone. Thank you for joining us. And today we are welcoming Dr. James Tulsky with us for this talk. Dr. Tulsky is the chair of the Department of Psychosocial Oncology and Palliative Care at the Dana-Farber Cancer Institute. He's also chief division of the palliative medicine at Brigham Women's Hospital and professor of medicine at Harvard Medical School. Dr. Tulsky has published widely in the areas of clinician-patient communication and quality of life in serious illness. His current research focuses primarily on enhancing communication between oncologists and patients with advanced cancer. His works have been recognized with the Presidential Early Career Award for Scientists and Engineers in 2002 and the Award for Research Excellence from the American Academy of Hospice and Palliative Medicine in 2006, along with several other prominent awards. He also serves as a board chair of the Greenwall Foundation and the National Palliative Care Research Center Scientific Advisory Council. So without further ado, I will welcome Dr. Tulsky again. Thank you for joining us and for giving this talk. And we would like to start.
Great.
Just like to add that James is a faithful friend of the Salim Hass Bioethics and Professionalism program, and we've been working together for quite some time, and it's great seeing you again, James.
Thank you so much, Diana and Talia. It's really a pleasure to be here. I wish I was in Beirut. And I have very fond feelings from the first time I came in 2012, came again a few years later after that. Really admire the work that you've done. I also want to just say that I'm very aware of a few things. I'm going to be talking about some ethical issues that have come up in COVID, particularly in our care of patients here. I want to acknowledge that our situation is just so radically different than yours. And the things that may sound hard to us may in some ways pale in comparison to what you've been through. We've all been through a lot in the last 2 years. But honestly, I think that you've been through more. You've had the experience of COVID like all of us with all of its challenges. In addition to that, the terrible blast that occurred, as well as now, the economic difficulties and resource shortages and fuel crises and all those things that I am very aware that you're experiencing. Just make your challenges seem so much greater. So I just want to acknowledge that what I'm going to be talking about is very much of a US perspective. Some things may seem kind of privileged. What I hope is that what I talk about will translate in some ways, because I think some of the fundamental issues I'm going to talk about are similar, and hopefully and that I think they raise some ethical questions we can all consider. So I'm going to go ahead and share my screen. Hopefully that's correct and you're seeing that now. And so what I decided to speak about when I was asked was I called it Triage, Dying Alone, and Staff Burnout, Palliative Care Ethical Challenges, and the COVID-19 Pandemic. And it really grew out of what our experience was as a palliative care service, taking care of and working within the COVID environment here, and a number of ethical challenges have come out. And so I'll just kind of walk through these. I also want to say that I plan to talk for about 20 minutes or so, which is what I was told, give or take a little bit. And then afterwards, I hope there's plenty of time for conversation and questions. But if something isn't clear or you have a question in the middle, please don't hesitate to just speak up. Or else put something into the chat and I'll hopefully see it. So I wanted to start by just describing our palliative care service. And I realize that this is, we have a very well-resourced service. So this is one of those places where we it may not be a fair comparison, but I say this so you understand what our experience was as we went into the pandemic. So we have an inpatient palliative care service for about an 800-bed hospital, the Brigham and Women's Hospital, which is one of the main teaching hospitals for Harvard Medical School, and it's right next to Dana-Farber Cancer Institute, and it's the inpatient hospital where all of our cancer patients go. But we take care of both cancer and non-oncology there. We have about a total of about 20 attending physicians who work for us, but at any given time, there are 2 or 3 attending physicians on consult service. We have 5 nurse practitioners. We have 4 physician assistants that actually work on our intensive palliative care unit. We have a total of 5 social workers, and we have chaplaincy and dedicated pharmacists. We have, like I said, we have a consult service, which we have basically established as 2 services, a oncology consult service and a non-oncology service. We also have some dedicated services for specific diseases. We have a program called Heart Pal and a program called Kidney Pal for those diseases. And then we also have something called the Intensive Palliative Care Unit, which we call the IPCU. And this is a 12-bed unit dedicated for cancer patients with advanced disease, not just dying patients, but people with very heavy symptom burdens who need intensive symptom management, pain control, other kinds of symptoms. Some of these patients are dying, but the majority of them do not die in the hospital. The majority of them go back home, continue living their lives, but we are managing them. You can see we have about 2,000 consults annually, and we have about 450 admissions to our IPCU annually, but many of those patients stay for a long time. So when COVID hit us, it's a little bit earlier than it hit Lebanon or at Beirut, but it was a little bit later than it hit some other places in the world and as well as in the United States. So the peak of the surge, of the initial COVID surge in 2020 was April 22nd for us. If you remember, at the peak, obviously in Italy it hit earlier, obviously in Wuhan in China it did earlier. But in the United States, it first went to Seattle, which had a terrible surge, and then it went to New York City, which really suffered. And then it came up to us. At the peak of the surge, our hospital, our 800-bed hospital, had 213 COVID positive, or PUI means people under investigation, meaning they had not yet confirmed positive, but they assumed positive. We had 213 patients outside of the ICU, but admitted to the hospital, and 98, almost 100 in the ICU. So we had a little over 300 patients out of a 800-bed hospital who had COVID, 100 of whom were in the ICU. And, but we had the advantage of being able to learn from these other places. So as we saw the surge coming. It was kind of like being on the shores and watching a tidal wave coming. And we knew it was going to hit us. So we actually had about 2 weeks to quickly get things together. And that period of time remains quite vivid to me as I remember how we planned for that. And we did a number of things. We had 4 main parts to our response to this. And this, I'm speaking entirely from the palliative care perspective, because the entire hospital did lots of other things because obviously it was changing the complete way we were organized. We discharged lots of other patients from the hospital to accommodate these patients. We created COVID units. We did lots and lots of different things. But from a palliative care perspective, what we first did was we had to restructure our entire consult service to focus on this problem. We also took our intensive palliative care unit, which was only for oncology, and we turned it into a COVID palliative care unit, primarily for dying COVID patients. So COVID patients who were either discharged from the ICU because they were going to die, or either chose not to get aggressive treatment, or it was felt that the aggressive treatment was not going to be helpful. Those patients came to our IPCU, and so it ended up about 45% of all the patients that died from COVID died with us on our unit. We created a palliative care toolkit for use for everyone in the hospital. And then we did lots and lots of staff support, trying to recognize that people were really struggling during this time. And I'll talk a little bit more about this. So what were the ethical challenges? Because this is really what the talk is about, and this is, an ethics group. And there are many, but I'm going to focus on 3 areas that really came up and forced the ethics questions. One was triage, and meaning, were we going to decide that certain patients could get certain kinds of care and certain patients could not? The second was family visitation, and whether or not we would allow visitors and what that was going to look like and how that was going to play out. And the last issue, which is perhaps not exactly ethics, but I think it does play into it, is staff burnout. So I'm first going to talk about triage. And as you know, triage is something that originated in war. And, the idea is casualties come in from the field and you have to quickly decide who could you save and who could you not. And it's a pretty tough notion to sort of really think about. But in wartime, you can imagine that. But the truth is, we were put into a similar situation with COVID. Now, we actually never got there. So I should say that everything I'm going to talk about was preparation for something that never quite happened. The main concern was, would we have enough ventilators to ventilate all the people who had hypoxic injury from COVID? And if we didn't have enough ventilators, what would we do? And we probably ended up using, at the worst peak, we were probably at about 95% of capacity, but we never got to the point where we literally didn't have a ventilator. I mean, we used the operating rooms, we used recovery rooms, we used lots of places and every ventilator we had, but we never ran out. I'm noticing, by the way, a question in the chat about the delay, why it came to Boston later. I think that it came later. Some of it was just sort of idiosyncratic where travel patterns were. Some of it is because of different patient populations. And some of it is because we probably initiated social distancing and other forms of precaution earlier on. So there were several reasons why it was delayed in Boston. So what happened was that we, while we were, thinking about this question of triage and when we're going to have enough ventilators, we had to come up with a system for how we were going to manage this. So crisis standards of care were developed, and this was actually something that had been created there. And the person who really done probably the most work in this area is an ICU physician and ethicist named Doug White at the University of Pittsburgh, who had written a lot about this and sort of proposed criteria by how you would make a choice. And the idea was, if we were going to initiate what are called crisis standards of care, which is a standard of care when you have to make a decision about triage. And they came up with these principles. One would be to try to save the most lives, but the other is to save the most life years. So for example, if you're going to save the most lives, but all those lives you save are lives that people are going to live a very short period of time afterward, is that also the same value? So basically, we ended up with a point system that included 2 different things. One was prognosis for short-term survival, which is something called the SOFA score, which is a scoring system in the ICU. And then the second was prognosis for long-term survival when you're looking at comorbid conditions. And then based on that, you could have a total point score of 8, you got a point score of 1 through 4 for each of these things. Saving the most lives or saving most life years. And then what we did was, and this, by the way, ended up being done, initially we were doing this at each hospital separately. This was an ethical issue because each hospital in the state, even in Boston, was coming up with their own system. But what this meant was that you might have a different likelihood of being ventilated if you went to one hospital versus another. So we were able to convince the state to come up with a statewide plan so that no matter what hospital you went into the state, everybody adopted the same scoring system and the same principles by which we would make these assignments. So then what happened was we had this program, we had this plan here, which was a priority score from this, multiple principal scoring. And we had a level of priority based on the score. So if you had a very low score, 1 through 3, then you were the highest priority for getting ventilated or getting whatever limited resource. And then you obviously would have orange, yellow, and green. It's funny because the colors, the green people, if you ended up, the green people didn't have any need for critical care resources. But the people in yellow, you would think that wouldn't be so bad. These are actually the people that were the lowest priority for getting something like ventilation and might be the ones who would die as a result. This was the system that was set up. But this raised many, many questions. And, a lot of the people felt very self-satisfied about having created the system that they thought was ethical and equitable and so forth. But there were many issues that came up. So one of them was, should other kinds of people be prioritized? I remember being part of a conversation where at the Department of Medicine at our hospital, where people were arguing very strongly that healthcare providers should get a point or lose a point or whatever the system would work. They should have an additional prioritization to get ventilation. And the reason was because they were putting themselves at risk, taking care of patients, and they ought to be prioritized. And in my mind, this was actually a very inequitable option because, first of all, it privileges those people who are healthcare workers who tend to come from the upper strata of society anyway, even though, yes, they're putting themselves at risk, but they're putting themselves at risk with protective equipment to the extent possible. The other thing was, healthcare workers weren't the only people. There are many, many other essential workers out there, and all the people that were arguing for having healthcare workers get advantage weren't arguing for other essential workers, like people working in grocery stores and people driving public transportation, and all of these people who tended to come from the lower strata of society and are just as essential and probably more at risk. And this led to lots of discussions. The final system that was put in place ended up not prioritizing anyone like this, which was a lot of work to get that removed. But what it struck me was a few things. First of all, how in the moment of crisis, emotion raises very high. And people start advocating for themselves in ways that really don't feel equitable. And also that you can take the most perfect system that you think is going to be able to, be equitable and triage people, and yet when you put it to the test, people are going to try to game it, and there's going to be a lot of other pieces that are going to still feel unfair. The question about this system that was put in place was created. This was all created weeks before the pandemic surge hit us. This was created specifically for COVID-19. Now it's on the shelves, so it could be pulled off theoretically for another pandemic or another kind of problem. Okay, I'm seeing some questions in the chat, but I'm going to move on and then try to come back to those later on. The other question that came up was around do not resuscitate status. So there was a number of people who advocated for creating unilateral DNR orders because they said, these patients are not going to survive a code, and we shouldn't even put them through it. And the big difference compared to usually the discussions about whether or not it's traumatic to the patient or whether or not it's futile or whatever. The big difference here was that a code was perceived as dangerous for healthcare workers. So it wasn't just that you were doing a futile activity, but that you were doing it and putting people at risk. I will mention that my own brother, who's also a physician and works at another one of the hospitals in Boston, he contracted COVID because of a code. He was attending to a patient who coded. He ran into the room. He didn't really properly put his PPE on. And within a few days, he was very sick. He never needed hospitalization. He got very, very sick. So I understand what this means personally. At the same time, the notion of a unilateral DNR was something that I always objected to because it feels like it's going to be enacted in an arbitrary way. Then what people started recommending was something called informed assent, which is basically telling people they're going to be DNR, and getting them to sort of assent to that with some information, which again, I think was a variation on the theme of unilateral DNRs and also problematic. We could talk more about that. But the other piece about this whole triage, that when the plan was put in place, nobody ever talked about, was that somebody ultimately has to enforce the rules. And it was kind of remarkable to me that we were about to, we had in place a program for triage. We had actually named triage officers for the hospital. We were ready to put this in place, and there were going to be people who were going to have to tell patients or their families in the emergency department that they or their loved one were not going to be offered a ventilator because they didn't meet the criteria. And there was no training for this. And we stepped in and we said, oh my God, how can you do this? I mean, do you realize the people that were being asked to do this had no particular communication skills training. And this is probably the hardest communication task I've ever seen anybody asked to do. This is worse. This is much worse than delivering serious news, like telling someone they have cancer, because you're telling someone they can't have something that actually is available to somebody else. So we then created a training program very rapidly, like several days. And we then ran trainings for all of these triage officers who were going to be in this situation, where we used patient actors and drills and simulations. And we came up with this as a talking map for helping them get through these conversations. And it was called SHARE, for discussing resource allocation. We developed this at Vital Talk, which is a nonprofit organization I'm a founder of, which is works on communication skills in serious illness. And the idea was it was a 5-step process. Like, you need to first see what the patient understands or the family, headline the key message, affirm the care you will provide, respond to emotion, and emphasize that the same rules apply to all. And this was something that we adapted from lots of other communication work we had done before. So I'm just going to walk you through what this looks like. We see what they understand. You need to introduce yourself and ask what the patient and the family have already heard. Hello, my name is Dr. So-and-so. I'm a member of our hospital's team that's thinking about how we care for our patients with COVID infection. What have you heard so far about your father's illness? You then have to headline the key message, because obviously if they don't know what's going on, you don't want to be able to give the message. You have to state clearly the key information the patient and the family need to know. So this is an example of what that might look like. Your father is very sick. We intend to take care of him here in the hospital. Unfortunately, the situation does not meet criteria for a breathing machine or care in the ICU right now. The hospital is using special guidelines about the ICU because we're trying to use our resources in a way that's fair to everyone. You then need to describe the treatments you can provide and commit to the ongoing care. So, we do plan to use medications on the general medical floor to help his breathing be more comfortable. And then we need to acknowledge the emotion, because this is going to get a very strong emotional reaction, and track and respond to the emotion throughout the conversation, with language like, I can imagine this is upsetting to hear. I can see how deeply you care for him. I wish things were different. And then emphasize the same rules apply for all, because many people are going to question that, and make sure that they understand the same criteria being used. I want you to know that we're using the same set of guidelines for every patient in our hospital and health system. So we then had a whole list of things of what else patients and families might say. What if they say, so you've just decided without us that my dad can't go to the ICU? This is an extraordinary time. We're trying to use resources in a way that's fair to everyone. I wish things were different. But I heard from the other doctor that my dad needs a ventilator. What if he dies? This is incredibly scary, and I'm worried about your dad too. We need to be prepared that he could die. We want to provide him with the best care we can. And finally, are you discriminating against him because he's old? Or what we frequently heard was, are you discriminating against him because he's Black or whatever? I can see it might seem like that. No, we aren't discriminating. We're using guidelines we're developing our hospital to prepare for a time like this. I can see how much you care about him now. So, or it sounds like you're playing God. You can't do that. I can only imagine how upsetting this is. It's an extraordinary time. I wish we had more resources. The point was we tried to teach people how to respond to the emotion that comes up in this rather than getting into an argument about the rules. Hopefully that would have prevented some more difficult conversations. Like I said, we never actually needed to use this, but we did put this into place. And I want to emphasize that whenever we think about this kind of triage or allocation, resource allocation, we need to also think about the other pieces, like the communication pieces that go with it. Okay, so what about visitor policies? So this was another huge issue. I'm sure that all of you experienced this as well. But because of our concern about infection, visitors were essentially not allowed in the hospital. And what happened was, and so the healthcare providers ended up becoming the people who were at the bedside. And families could only come in by, via Zoom or some other media, FaceTime, whatever. As the palliative care team, we found that much of our job ended up being bringing families to patients and communicating and being the intermediaries between the teams who were so busy taking care of the patients and the families and the patients and trying to make decisions. We actually had to go out and buy iPads and baby monitors and so forth to be able to follow patients and to be able to allow people to communicate, because we weren't even set up to do any of this. But it really then, raised the question of what should, what kind of suffering happens when families can't be with their loved one when the loved one dies. So when we created our intensive palliative care unit for dying COVID patients, we were able to get the hospital to make an exception to the visitor policy for our unit and allow like one person in a day, and we had all sorts of restrictions on it, which then led to a series of other challenges. So first of all, as I already mentioned, one thing that came up was, on one hand, it might have been obvious why the hospital was restricting visitors because of the risk of spread of infection, the pandemic, risking more death, which is all a physical risk. But there really was never an accounting or a calculus of the emotional difficulty. And I don't think we still know what the trauma is and what the results are and what the aftermath is of all those people who watched their loved ones die from afar. And so I think that's something that never was really brought in as part of the calculus. And I think the question from an ethics perspective is, how do you judge emotional trauma versus morbidity, mortality? How do you stack those things against each other? The second thing is that it was we created an impossible choice, because when we allowed on our COVID palliative care unit outside of the ICU for visitors, what ended up happening was patients suddenly got this choice, which was they could pursue aggressive ICU care and have nobody in the room with them. Or they could actually come to our intensive palliative care unit where the expectation was they were going to die, but they could have a visitor. And that, presented its own ethical conflict and dilemma. Okay, the last topic I'm going to touch on, and then we'll be done, is staff burnout. I love this photo. I think it just sort of shows what people were experiencing, taking breaks whenever they could. And it was a very, very hard time. It remains very hard. I'm going to get to that in a moment. But I think all of you can relate to this, and I'm sure you have similar experience in your own hospitals. But I think that from an ethics perspective, I mean, this was very hard on the staff in lots and lots of ways. But the things I struggled with were, I found that my staff had, the best way I can put this is a variable risk tolerance. And that there were some people who, just were willing to put themselves in harm's way. They were less scared, or their mission moved forward more so. And there were other people who were just deathly scared. And even people who had the same level of risk, whether it was comorbidities or whatever, had very different tolerances. And some people just refused to come in. And we had somebody who had a history of treated breast cancer and just felt like she couldn't come in. And so this was something we had to struggle with. And then the other is, how expendable are staff? I think it's something that we have to wonder about when we are dealing with any kind of situation that's putting staff at risk. And then the last piece that I'm beginning to really grapple with now is short-term versus long-term. Like, we thought we were in this for the short term, and so people were willing to put up with a lot. But two problems. One is, as everybody knows, COVID's not gone away. And the staff challenges and burnout have not gone away. So that's one problem. The other is, how do we try to prevent long-term harm to our staff in a situation like this? We did lots and lots of responses. We actually created, we had weekly remembrance rounds and psychosocial rounds, and we had a daily psychologist drop in office hours for our staff, and we had fun things. We did, we had a dog show on Zoom, and we did lots of things to try to distract people and to try to provide support. But at the end of the day, people still had a lot of burnout. And one of our physicians, our Ricky Leader, who's a beautiful writer, he's written a lot in the New York Times, written in the New England Journal. He wrote a beautiful perspective piece in the New England Journal of Medicine about his experience. And Ricky was the physician that took the lead of our team that was liaising with the liaison to the COVID intensive palliative care unit. Intensive care unit. And he was just working with these families and everything all the time. And what he wrote in this article, which he wrote a number of months later, he said, when the surge abated and our COVID ICUs began to shut down, I couldn't help but feel an overwhelming sense of relief. We did it, I told myself. We made it to the other side. I was wholly unprepared for what came next. The weeks since Boston temporarily beat back COVID have been more difficult than I ever expected. When I fall asleep, I'm haunted by memories of patients I cared for but never met. I hear their families' wails, expressions of gratitude, and most often stunned silence. I can't remember their names, but I also can't forget their stories. And he finished the piece by saying, while we try to heal from the collective trauma we experienced in our hospital over the worst 4 months of the local pandemic, I struggle to know where to look. Peering into the future, given what we see on the news, saturates me with dread. And he wrote this about 12 months ago, and he was fortunately too right. And yet it's too early to look back. Perspective can't develop in the presence of open wounds. And, I found this really powerful. And the question is, what have we done to our healthcare providers, and how do we manage long-term trauma? I mean, what he's experiencing is really PTSD. And how do we manage that when we have to keep going back in and in and in? The analogy to being a soldier in war is not really so different. And it's something I don't think we've quite figured out. And I'm not sure what's happening in Beirut and in Lebanon, but here we are losing healthcare workers like crazy. And we have about a 30% nursing shortage. It's terrible. And it's because of, I think, partly because of this. So I'm just going to leave you with a few takeaways, and I would love to have a conversation, and I'll get to some of the things I saw come up in the chat. So takeaway number one for me is that brilliantly considered ethical plans, for example, the crisis standards of care, require real-world implementation. And when that's the case, we need to consider lots of things, including the emotional response to doing something like that. And that was simply not figured in when they first created those crisis standards of care. Second, it appears that survival trumps emotional distress and caregiver suffering in most of the decisions that are made by healthcare systems. And while I understand that life is preeminent and life is the thing we often work toward, I do worry that sometimes we discount the toll that's taken from the, people are going to live, and they're going to live with terrific suffering. And then finally, I think we need to consider how to manage personal trauma in the healthcare setting and move forward. And, none of us know what the future holds, but it doesn't look bright right now with, Omicron happening and everything else. And so we need to continue to think about this and how we can support our staff and each other. So with that, I'm going to stop sharing, and happy to answer any questions. I'm going to look in the chat a little bit. Seems like there were a number of things here.
So that's why I'm not going to ask anything. You already have a plethora of questions. So
yeah, if you want, so let me just try. I'll try to go through it. So let's see. So this is really not related exactly, but question about whether our chaplaincy service caters to all denominations and religions. The answer is absolutely yes. Our chaplains, although most of them come from a specific denominations, do work with all different kinds of patients. I answered the question about Boston. Economic costs of the healthcare system when using these scoring systems. So I will say, to the credit of everybody, the economics of this did not come into the discussion. And we were not triaging for cost, we were triaging purely for availability. Cost was never something we were triaging. I answered the question about whether the triage system was specific to COVID. Should someone with dependents be prioritized over those who have no dependents? Interesting you say that. That was not in the system that was developed. But the answer could be absolutely yes. But that was not included in the system that was developed. Should junior physicians be expected to work in such wards? So we did not have medical students work in the hospital during this time. And I think the feeling was that they were students, they were actually paying for their training, that they were being put at undue risk. However, the early career trainees who are employed physicians, interns, residents, fellows, etc., absolutely did do the work. Without them, we could not have done the work. What we did with our fellows, our palliative care fellows, was we did have them work, and we actually repurposed what they were doing, and we tried to make it a learning opportunity for them to learn about leadership in a crisis. How do you balance fairness versus equity in a resource scenario? So this was it. I mean, this was the biggest struggle, because when you start looking at things, the equity questions kept popping up all the time. For example, obesity is a comorbidity that increases patient death in COVID. And you could say, well, that's just a comorbidity and it's going to raise your score. So therefore, people who are more obese are less likely to get ICU in that system, would be less likely to get a ventilator. However, obesity in this country tracks with race and tracks with food quality and other kinds of socioeconomic factors. So when you say obesity, you're probably also discriminating against certain class of people. And so it gets very complicated very, very quickly. Would you share the guidelines with us to yeah, I would be happy to offline, maybe Tala or someone, Talia, can reach out to me, and I'll be happy to share the Massachusetts crisis care guidelines, and you can distribute them.
Sure.
One of the patient's relative didn't accept the issuing and reacted in an unexpected way. So, like I said, we never actually had to employ these standards. So we never had that experience, but we prepared for it. We were prepared for if somebody reacted violently, or so forth. And that was the risk. But, I think the reason we did the communication training was before that, we didn't even have them prepared for how to react to that. So, thankfully we never had to employ it, but I would not have been surprised if somebody would have reacted in a very bad way. I wonder if the infection control policies didn't delay the healing at all because of psychological discomfort for not being with loved ones, and the hidden message that their situation is quite critical, as no one will see you. Yeah, I do wonder about that. I don't know the toll of the emotional pain and whether that changed things. And that's the part that I think I'm trying to get at is we want to weigh the emotional pain with the physical pain or morbidity or mortality. We don't even, but it may even affect mortality. So I agree. I think that's a good question. How, if at all, were bedside ethics consultants involved when the need arose? So our ethics committee did get involved. They were very, very involved in helping to shape the crisis standards of care. They were involved in the training that we did around that. But because we actually never had to ration, in the end, we were very close, but we never had to. I don't know how many ethics consultations actually happened around cases. The communication strategies noted are very important. Will these actually work, say, if you're in Memphis and the patient's African American who already feels that you're discriminated against? Well, so the answer is it's going to work better than nothing, and yet you're still going to have people be very upset. It wasn't the communication strategy. This was the key piece. It wasn't changing anything. The rule was going to still be abided, and people were not going to have a way out of it because that was the rule that was going to be set down. We were trying to do this in a way that would address the emotion behind that perception of discrimination. But, that was exactly the thing that we were worried about, Talia. And, people already do feel discriminated against. We were able to circumvent the negative effect of PPEs, hazmat suits on patients, especially pediatric patients, some of whom already have the white coat syndrome. Honestly, not very well. I think with pediatrics, in pediatrics, they did allow parents in. So we have two hospitals on either side of us. One is Brigham and Women's Hospital, which is the adult hospital, and then Boston Children's Hospital is on the other side of us. And in Boston Children's, they had very, very few cases of COVID and very, very few cases of serious COVID. Because if you remember early on, children really didn't get affected that badly and they didn't get super sick. And in fact, there was a belief that children weren't really susceptible, which wasn't true, but it was very different. So at Boston Children's, they were more relaxed about the visiting rules. So the way they got around it was they had a family member in the hazmat suit with the child that I think was probably helpful. It wasn't just it wasn't just the PPE and everything. It was also, people were going in the rooms for very brief periods of time and coming out. In our intensive palliative care unit, COVID palliative care unit, we actually set up, I mentioned, we bought baby monitors and we put them in all the rooms. So we were at the nursing station, we could see everybody, but we would only run in when we absolutely had to be in there. Again, just terrible isolation. Should people providing specialized healthcare and special training in resilience management? Yes, yes, yes. I think the answer to that is absolutely. we need better training in resilience. And we're actually going to be having a department meeting tomorrow, and we're doing a values identification exercise as part of resilience. We're trying to teach our whole department. SOFA score criteria does not include age and other comorbidities and frailty. It's how it's reflected in the score. I think age was deliberately not included because it was felt that was going to be discriminatory. So this is so it wasn't included. Frailty was not either, which is, was maybe just kind of, and maybe it was felt that it would be too hard to do that. I'm not sure. Should the person who explains guidelines for resources be a social worker, a psychologist, simply any healthcare professional provided with the training you talked about? Because these types of discussions need skill. So, yes, it was felt that the message had to be delivered by a triage officer who was a physician. So, therefore, it was MDs who were going to be delivering the message. However, they are not necessarily the most skilled. We gave them some training, but they are not the most skilled at doing this. As you mentioned, a psychologist or a social worker or a palliative care physician is more skilled at doing this kind of messaging. Ideally, we were hoping to do this in teams where you would have two people delivering the message, or that there would be a psychologist or social worker that would do follow-on. But this was a tension we went through. The issue with having a social worker do it by themselves would be that they wouldn't be able to necessarily address some of the medical questions. Let's see. Would you argue that there's a need for a special training for palliative care and the elderly? I'm not exactly sure I understand. You mean additional sort of like geriatrics within palliative care? I think that most of what we learn in palliative care applies to most older people, but we don't focus on a lot of the frailty sorts of issues and other things that are essential to geriatrics. I do think that there are many people in palliative care who are dually trained in geriatrics. We have a number of them in our department. So I think that it's absolutely complementary and helpful. I think it maybe depends on the population you're caring for. A bit of an unfair question. When you ration healthcare resources, are you also rationing ethics? I'm not sure if I understand the question. So I'm not sure I can answer that. I'm happy to come back to it. How do you imagine palliative care with the possibility of having humanoids taking care of patients in times of pandemics? I believe you mean, when you say humanoids, I believe you mean some sort of robot. I think, there are already ways of going through, like, for example, you can have there are these robots where the person, the real clinician is on the screen, but it's actually a robot that's doing everything. I certainly think that that's a way to go. I mean, the main thing is you're trying to create human connection. And however you can do that is what's most essential. How did you deal with the moral distress injury resulted from triaging scarcity? Well, this was the thing. We had, I showed a slide, we had psychology drop-in rounds where you could come in, several times a week when you come and talk to somebody. We did lots of activities of sort of trying to help support people. And it was hard. It was hard. So I think I made it through most of the list. Happy to answer any other questions in the last 3 minutes.
Superb, really. This is amazing. Thanks a lot for the time and the patience to answer all these questions. And I apologize for asking so many myself. Anyone else has a question? Diana, Tala, our colleagues, Dr. Majdalani, you work a lot with pediatrics. You are a pediatrician, actually. And we have seen a lot of children in the ICUs, and you and I often talked about the importance of having palliative care. So the floor is open. Well, James, I guess you overwhelmed everyone.
Well, thank you for the opportunity to speak with you. As always, it's great to be with my colleagues in Beirut. I wish you all well, particularly through all the challenges you're living through. I'm hoping that things get better, and wish everybody a wonderful holiday and New Year. So thank you.
And to you too, James, and hopefully we'll see you soon in Beirut.
Okay, I would love that.
Okay, God bless. Thank you. Bye.
Thank you, Doctor.
Bye bye.
Goodbye. Thank you.
واحد عزمته كذا مرة